I just was given the task of talking about how I've spent the last 20 years or 19 years and sort of the role that Harborview Orthopedics has had on the evolution of percutaneous pelvic surgery, not acetabular surgery, but pelvic surgery. This is a patient that came to my clinic last year, and this is one of Dr. Hansen's old slides that he loaned to me when I was a fellow of a spica cast and an external fixation combination. But you know that the closed pelvic treatment, or you may not remember if you're young, the closed pelvic treatment didn't do very well, and there were significant consequences for treating patients with closed management. This lady that you see here that came to my clinic, I think it was this year or last year, she was treated just a month or two before she saw me, and she had an x-ray of non-displaced fractures, and this is what she ended up with. And so it was pretty impressive to see the consequences of what had happened with just what was thought to be hopeful care and minimally displaced fractures that were thought to be stable, and the pain and the deformity and the inability to work and the costs that were associated with closed management just didn't work. And when I was a resident, this became grossly obvious to me. Open pelvic fracture care came along with the AO group as the principles sort of diluted or eluted in. They dripped into the pelvis, and people found that there might be some bleeding associated with the open pelvic care. There's hematoma was something that a lot of people feared, at least of my when I was a resident. The exposures were often very unfamiliar. Urologists and obstetricians were helping orthopedic surgeons get to the bone, which is a little bit unusual since fan and steels are different for a lot of different things. And then infections really scared people a lot, the deformities that occurred. And you can even see now, this is an x-ray that was loaned to me about 3 years ago, and you can see some really fancy implants and combination of implants, but still a fairly poor understanding of open pelvic fracture management. And for this reason, I think closed manipulative reductions and percutaneous fixation sort of took off. Manipulative reductions were a good thing. You could pull on a leg like you see here in this flight attendant, and you could make some small wounds if it lined up, and you could do this very early. You could even make it resuscitative, and it can be definitive. One of the things Larry talked about earlier is you don't want to just sort of be damage control, but this is sort of damage control that can also be definitive. There's not much blood loss at all. It allowed the patients to be quite stable and mobile. You can stand them on their head or stand them up, whatever you want to do, and then the complications really depend upon how good of a reduction you get, and then your knowledge of the osteology. You can imagine the costs associated with this if you do it the day of or the day after injury, and then they're up and walking. It's quite good. There were some real relevant factors that contributed to percutaneous pelvic surgery. And when I came here with Mark in 1988, it was shocking what I had just stepped into. And I remember there was a precedent for quality that I'd never, really was pretty much unfamiliar with. It was astonishing. And, the other thing that was really very apparent to me was the institutional attitude of excellence. And I'd worked in nice places before, but I'd never really seen an entire institution that was right on the edge of arrogance for what they were doing. And I really liked it. As a Texan, it really appealed to me to see people really walking their talk. And then I think the thing that it all breaks down to is really the people. And it's not just the patients, but it's the regional clinicians. The thing that made this work, at least from a pelvic standpoint, I think from the traumatology overall, is the regional clinicians supported this place, and they send, and they continue to entrust us to take care of their patients. And this is a really, really good thing for us because it drives our experience and it drives the center's excellence. And then the quality of the patients here is just phenomenal. Dr. Kopis, I don't have to say any more about him, but these were all the things that I think were relevant factors that drove it. And then I think having the faculty that I get to work with be very supportive of this in 1991 and say, I can still remember Brad Henley when I said, do you mind if I take call like every night for pelvic trauma? He went, oh yeah, that'll be very good. And between the orthopedic surgeons allowing me to take care of their patients and the general surgeon, urologists, and the intensive care crew and the house staff and the ACEs helping take care of this, been very good. And then y'all all know Tom Olson, and that's the new Jane is down here, Bethany, with Ted. And then the other thing that really drove it was Alan Tenser's biomechanics lab that Mark had a big role in and Dr. Hansen had a big role in, and that really drove percutaneous fixation as well, because we were able to do biomechanical studies that allowed us to sort of either test or prove what we thought was right. Like Doug, I just have a few little things that we'll touch on that I think Harborview had a role in for percutaneous pelvis. Julius has sort of showed you the osseous fixation pathways. And then I think I want to just amplify Sam Agnew's role in helping us learn the osteology and the imaging of that when not just when he was a fellow here, but after he had gone away, he came back. And then just the instability principle, early fixation, reproducible safety, and just a few other little things. These are the osseous fixation pathways that Julius showed you all yesterday. If you weren't here, these are sort of the tubes of opportunity for putting straight implants in a curved bone. They're not so morphologically simple, but that's how they break down, and this is just a few of them, and these are the sort of the common ones we use, and we do use these. It just sort of shows you we do use these, and they help us a lot. I think there was a good move here, and Alex McLaurin, one of Jim's old colleagues, sort of put me onto this at a meeting in the late 80s about the ala, and then we sort of took the alar anatomy onto what a normal sacrum and what a dysmorphic sacrum was, and we saw that there wasn't just a variety of upper sacral segment pathology there, osteology, there was a real spectrum of it. And then our challenge was to correlate the imaging of it so we could reproducibly do it, and that involved the upper and second sacral segments, not the third. The third doesn't have any iliac coverage, so it's irrelevant. But this we found was very learnable anatomy, if that's a word. You can really learn this. And so the navigation systems we still think are pretty much yuck because the doctors have the brains that can learn this. We've heard early on about starting point and all these different things that were so critical. And the reality is the starting point really didn't matter, and the aim didn't really matter, and the length didn't. It all mattered. Every single detail mattered about this screw insertion, and that's just for an upper sacral segment iliosacral screw in a non-dysmorphic patient. But we knew we had to put these screws into the bone and do it safely. And so the things that sort of sorted out for the osteology was the upper sacral segment as a pathway, and we learned a lot about the iliac cortical density and its relationship after reduction to the alar and how to read that preoperatively, and we realized where these zones of bone were to put screws. And then once we sort of figured that out, and then we had some manufacturers that actually helped us get implants that would accommodate this area, we were able to drop into 2 as well in the second sacral segment, especially we started off in the dysmorphs and ended up in the regulars as well. And so we found on the lateral sacral view, as Alex McLaurin showed us, these areas that could be tolerant of iliosacral screw fixation, and we learned a lot about the anatomy so we could put through and through screws in the upper sacral segment once we got through and through screws, and then we didn't have to, but we could also use multiple level fixation, which has been something that's been very beneficial as well. And this is just for the sacroiliac and sacral fractures, the posterior ring pathology. When Sam finished his fellowship here, he went off and practiced for a couple of years, and then he came back and he said, "Boy, I sure would like to do a project on these sort of stupid-looking upper sacral segments," and we didn't know what to call it, so we called it dysmorphism. And literally in an afternoon, looking at about 100 CT scans that used to come in jackets, not on a PACS, we looked at 100 CT scans and 100 X-rays, and we were able to put together a little example, if you will, of upper sacral segment dysmorphism, which means nothing to anybody unless you're trying to fix sacroiliac or posterior ring pathology. And so I think one of the contributions here was the dysmorphism and how it relates, and you can see sort of what we call normal on top and the dysmorphs below it on the inlet and the outlet imaging of these models. And so that allowed us to see that for the upper sacral segment in the yellow here, it had to be different. The implants that we used had to be different, and then the second sacral segment was more like the upper sacral segment in a non-dysmorph. And that was really good. I think a lot of people got a lot out of that, at least from when I interact with people, they seem to really like that a lot. Acute pelvic instability wasn't really hard to sort out. People get it. You look at you can show this to anybody and say, "You think that pelvis is stable?" It's like no one's going to say that's stable. And so these obvious ones weren't so hard, but really it was the ones that we all never wanted to operate on. And people still, this is still something that's really hard to teach people, is to listen to the patients and to take a history and to feel the patient's pelvis. I mean, this still goes on today, and it still goes on here sometimes. And we have patients that are horribly in pain. They've had a pretty good mechanism, and there's just a resistance to treat sometimes. And all you have to do is just feel them. And if you just put your hands under that crest and crush it, and it's still a challenge to teach people to examine a patient and to feel these more subtle instabilities in patients that have, non-displaced fractures but very unstable ring injuries. And we can, very simplistically take care of this and give a patient comfort to where they can mobilize and go on about their business. We also learned that you could do this as a part of resuscitation. You didn't have to just put an external fixer or an anti-shock clamp or whatever device or a spica cast. You could just put a screw in, and a screw would close down the posterior ring quite nicely. It worked quite well, and if you knew how to do it pretty good, then it can be definitive. You can run people off of that. And then we also learned that this technique is about 99.999998% safe. This is not a dangerous technique at all, as long as you get a good reductions and know the osteology and have quality fluoroscopy. You say, well, that's a lot of ifs. Yeah, but I mean, that's just the way it is. It's just it's the cost of doing business. But if you plan and you understand and you have a sufficient patient volume, we've really evolved into a safe technique. And then, of course, I think most of you that have worked with us know that we assess every single one that we put in. We get a CT scan to see and make sure they're safe. So, in summary, I just leave you with the contributions, or what you would say Harborview has done for percutaneous. I think it's the osseous fixation pathways that have been quite good. This can be done closed. I think using this early is quite good. Provides good stability and allows us to move on. And I think you can imagine, one of the things we don't ever talk about is the cost savings of this technique. And I think we've saved millions of dollars in healthcare dollars just by doing percutaneous fixation and getting people up, getting them alive, getting them back to their jobs and getting them back to work, and not messing with them too much. Thank you.
Thank you very much, Chip. One of the greatest things about the Harborview legacy is we've created more leaders and champions around the globe than almost any other institution. And I'm somewhat of an archivist of the career registry, if you will. And Thomas, who is a graduate here, ACE here, is now professor and chairman. Yes. And now I think he sort of puts us over the top. Harborview now has legacy of more chairmen than any other university or institute of higher learning. So without further ado, our next speaker, Thomas Schildhauer.
Thank you very much. Well, good afternoon. I think the lumbopelvic fixation story is also a story about stubbornness. Lots of this technique was developed here during my time here at Harborview, and I'm really happy that I'm allowed to talk to you about that. We all know that the standard and well-accepted techniques for osteosynthesis of the posterior pelvic ring are SI screw osteosynthesis and plate osteosynthesis and combinations of these. However, we all know and have seen complications with that, loss of reduction, although we don't think that it must be that high, like 26% in the cases in some of the publications. One possible principle of solution to that problem, however, would be an additional anchorage of the osteosynthesis to the lumbar spine. And this has already been described in 4 publications in the beginning of the 90s. These, however, differ in that 3 of the publications describe just a vertical stabilization, and only the first publication from Bochum, after suggestion through Professor Moore, said that in a horizontal and in a vertical unstable situation, you should think of an osteosynthesis which is stabilizing in the horizontal direction with an SI screw, for example, and combined with a vertical fixation, a lumbopelvic fixation. And we called that the triangular osteosynthesis. In a follow-up study, we were then able to show that these patients were actually able to fully weight bear, pain adapted, and ride away. So far, so good. But in the increasing geriatric population, we saw still problems with this fixation technique. So especially in osteoporotic situations, but also in situations where there were fractures in the posterior ilium, in this area, in situations with tumors, infections, and so on. And that was mainly due to the fact that the implants which we used were pedicle screw implants, which had a maximum length of up to 60 millimeter. And that is when Jens Chapman actually came into the whole game and suggested to use longer screws. And that was the time when I came here to Harborview, and actually through that, lots of studies have initiated. The first study was a radiographic and anatomical study where we tried to find an optimal bony canal in the ilium where we could position longer and stronger screws. And we were able to define the canal between the PSIS and the AIIS for such screws. This canal is nothing new. We know that canal from the work from Le Tournal or from the Galveston technique. However, what was new is that this canal has two cortical constrictions. So if you have screws which pass these two constrictions, then you will have a much stronger anchorage than with a short pedicle screw, which is just holding in the cancellous bone of the posterior ilium. So you can compare that to the pedicle screw, which mainly holds actually in the pedicle and not in the cancellous bone of the vertebral body. And this was the basis then to use and actually to get accepted longer ilium screws with a thickness of 7 to 8 millimeters up to a length of 12 to 14 centimeters. The next step was the question, can we actually insert such screws under regular OR conditions without using a fancy navigation system? Well, we defined three C-arm views which help us to make sure that these screws are contained intraosseously. This was first the lateral view, then the obturator outlet view, which shows this nice teardrop, actually a cross-section of this canal, and then finally the obturator inlet view, which shows the containment of these screws. So far, ladies and gentlemen, all biomechanical studies in human specimens have shown that there is no real difference between the different various fixation techniques of the posterior pelvic ring. And we wanted to find out whether this additional fixation, lumbopelvic fixation, is really helping us. So we created a pelvic testing apparatus with a free-floating pelvic testing system, which allowed us to actually load this system in a single limb stance model up to 10,000 cycles. And we found in this study a highly significant difference in the stability when comparing triangular osteosynthesis to a standard SI screw osteosynthesis. This fact is actually due to three principles. The first is that the upper trunk loads are directly transferred to the ilium and then bypassing the pathology in the sacrum. The second principle is that the lumbopelvic fixation is working like a tension band posteriorly, and if you use it bilaterally, it works as a tension band also in the horizontal direction. The third principle is that the long ilium screws, as you can see in this picture, are a much better counterforce in flexion deformities when looking here at the pivot point. So far the theory. Now let's look into the actual operative technique. And I want to highlight here just a few points. Initially, the ilium screw is positioned, and then the L5 pedicle screw from the lumbopelvic fixation. And using an extension on these screws, you can use these as joysticks for reduction in the vertical direction, but also in the horizontal direction. So you are applying distracting forces over the fracture. After you have done that reduction, you have to perform the horizontal fixation, for example, with an SI screw. But it's very important that after that, the distraction force is released, because the lumbopelvic fixation is not a distraction osteosynthesis, but a bridging osteosynthesis. So only then, after releasing the distraction, then you're finalizing your lumbopelvic fixation by taking off the distraction force. Indications. In my hands, I use the lumbopelvic fixation combined with an SI screw in these mentioned indications. So highly unstable posterior pelvic ring injuries, severe osteoporosis. L5 is one facet involvement which seems to be associated in these type C injuries, according to Isler, in almost 40%. But also in situations where the lower extremity is otherwise intact and where I want to allow full weight bearing on that extremity. For example, if you have, like in this person here on this side, a situation contralaterally where you cannot fully weight bear. Other good indications are spinopelvic instabilities, and we heard about that yesterday already. This is an example of a colleague actually with a plasmacytoma, and you see here in the upper corner that he has had pathological bilateral sacral fracture combined with a vertical fracture of the ilium. He was 6 months wheelchair bound, and as you can see, a regular screw or plate osteosynthesis would not gain much stability in this area. So we performed a lumbopelvic fixation bilaterally in this situation. We actually stabilized the ilium fracture with these long screws as well. And here you see the patient during the first week postoperatively. And here you see the patient at his first year postoperative follow-up. Now, we had a complete series of patients with severe high-grade spinopelvic instabilities here at Harborview over a period of 5 years, and these results were addressed yesterday as well. In these, we could show that there was a very good postoperative reduction and that there was no loss of reduction despite early full weight bearing. In conclusion, I want to address a few points again, which I think are really important when performing triangular osteosynthesis. The lumbopelvic fixation in this technique is not a distraction osteosynthesis, but a bridging osteosynthesis. The screws at the ilium here at the PSIS have to be recessed, otherwise you may risk soft tissue problems. The screws which you should use should not be chain screws, should not be partially threaded screws or tapered screws, and they should have a length of more than 90 millimeters and a thickness of at least 7 millimeters. I want to thank all these persons who were involved in all of this research, and thank you. Due to Harborview, a lot of work was able to be done in this regard. Thanks.
So the last lecture is going to be delivered by Roland Kent. He came to us from the Portsmouth Naval Residency, and that's where he's going back to be an attending. As you can see, he's going to be talking about lumbopelvic fixation, our experience in the last 10 years or so.
Thank you very much. So since 2002, we've identified several more patients at Harborview with spinopelvic dissociation. And we've made some attempts to change the profile of the screws so that hopefully they will be less symptomatic. We place them more anteriorly in the PSIS, and we use lower profile rod contouring to help decrease the symptoms associated with this prominent hardware. So the purpose of this current study is to assess the radiologic, clinical, and neurologic outcomes of patients treated with sacral decompression and lumbopelvic stabilization, and to compare our experience with that was gathered up to 2002 to see if we've made any difference. And our hypothesis is that while institutional and surgeon experience may improve the surgical technique, that these are very difficult injuries with a guarded neurologic prognosis at best. Just to let you know, the incidence at Harborview, generally we treat 240 sacral fractures a year. I draw your attention to the bottom line where only 3.8 of these fractures, or 1.6%, are treated with lumbopelvic fixation. And here's a pie chart demonstrating the treatment regimens for sacral fractures at Harborview. So we identified 22 consecutive patients from January 2003 to October 2008. 3 of these were failures from independent SI screw fixation. 8 patients only had unilateral fixation, and the average follow-up of these patients was 26.3 months with a range of 1 to 85 months. The demographics, average age was 37.6 with a wide age range from 16 to 68, 11 males and 11 females. The mechanism of injury is listed here, the most common being motor vehicle accident. So the concomitant injuries were pretty much prevalent in every single patient save one, the most common being extremity fractures. It's also important to note that there were concomitant spine injuries in 36% of the patients. So our preoperative kyphosis was 34 degrees with a range of 8 to 70. Historically, meaning our other paper, it was 43 degrees. Postoperative kyphosis was 25 degrees, which gave us an average correction of 9 degrees. There was no failure of fixation or loss of reduction in this patient population. Wound-related complications were about 36%, leading to infection. And then also of note, about 23% or 5 patients had symptomatic hardware which required removal or subsequent revision. So comparing our data from the 22 patients we gathered more recently to the 18 patients that were gathered previously, we see that our average Gibbon score improvement was 1.2, is currently 0.7. Our reduction in sacral kyphosis was 23 degrees as opposed to 9 degrees. And wound-related complications are 26% versus 36%, and hardware-related complications 11% versus 23% in our current data. So conclusion is that despite our increasing experience, in comparison between the historic controls, fails to demonstrate improvement in neurologic outcomes. As far as the radiographic data is concerned, we saw no improvement in the sacral kyphosis. There's a question as to whether this may be somewhat surgeon dependent, and whether there's less pre-op kyphosis, which I think we demonstrated is not the case with our historic controls. And then the question remains, is there any clinical significance to the resultant sacral malalignment? And I think that question still is hovering out there and would be difficult to answer with our current data. And then we also noted an increase in hardware-related symptoms despite our paying more attention to this. And some of this is also somewhat surgeon-dependent and patient-dependent as far as their expectations following surgery. So the strengths of this study is that our combined data set now is about 40 patients, which is the largest data set of patients with spinal-pelvic dissociation reported in the spinal trauma literature. Limitations of this study, of course, is that it's a retrospective case review. It's statistically underpowered, and that the Gibbons criteria, as we alluded to, is I think an inadequate measure of neurologic function in the spinal pelvic dissociation cases. And the reason for that is it's a very broad classification scheme that does not allow for a gradual improvement in bowel or bladder function to appropriately assess improvements in neurologic function. So what is the future directions? One, if we can look at the clinical significance of the resultant sacral kyphosis. 2, examine patterns of neurologic compromise in spinopelvic dissociation to devise better measures of improvement, meaning expounding upon the Gibbons criteria. And then 3, recognition of fracture patterns that fail other forms of treatment so that we can better decide which patients would benefit from lumbopelvic fixation at the get-go.